So I think in the first line, we now have the SEQUOIA, as I mentioned, in different cohorts. We have Zanubrutinib as a very established treatment based on arm A and B, superior to chemotherapy. So for patients without del(17p), it's something we've been using and is a very widely used and accepted treatment option. For patients with del(17p), the arm C of the study provided pretty similar efficacy and also CR/CRi rate compared to Zanubrutinib arm of the randomized portion of the study, basically meaning that factors like IGHV status and del(17p) status don't seem to impact the efficacy of Zanubrutinib in the first line, at least with the current follow-up. So we have that as monotherapy in combination with venetoclax. We reported and published the SEQUOIA D cohort, which looks at the combination with venetoclax, and that's another option that, with the safety and efficacy that is there, could be utilized in patients in the first line. In the relapse setting, of course, from Alpine, we did have the data, and it's continued to be shown to be effective. To answer your question about the relative efficacy compared to other BTK inhibitors in the absence of head-to-head trials, except for Ibrutinib, where there is Alpine data, we don't have direct comparison to other BTK inhibitors, but we have done a number of indirect comparisons as you know, we've done in the past few years, showing that Zanubrutinib remains a very effective and probably more effective than other drugs in those indirect comparisons, considering all the limitations. We have the switch study showing that patients coming off Ibrutinib or Acalabrutinib due to intolerance could remain and benefit from Zanubrutinib for efficacy. So I think overall Zanubrutinib is a drug that has its basically place in different settings for CLL patients, and we just need to follow these patients longer and learn about the long-term efficacy.